Hi, Aidan.
Hello.
How are you?
Yeah,
Dr.
just
Rani, hello.
recovered. I'm just recovering from another COVID infection.
Oh, wow.
Too bad. Thank you for all your
Th
preparations.
Thanks, Aidan. Thanks for joining in. Dr. Rani, good evening. Dr. Vijay, good evening. Hello, Dr. Rina.
Good evening.
Hi, Dr. Nihaal. Hello,
Hi.
everyone.
Okay. Yeah, I'm just waiting for Dr. Vivek, I think. Let's see. Let's see. Okay, let's see. Fabricio, hello. Nice to see you here.
Hello, my friend. This is the first time that I'm able
Thank you.
to watch you, and I'm very grateful and appreciate this meeting. Okay, thank you so much. Very
Thanks,
nice to see you.
Fabricio. Thank you. Likewise. Okay, we have Dr. Vivek. Let's see. Anas, if you're there, you want to start your case? I think Dr. Vivek hasn't joined yet. Let's see. All right, I will start off with your cases then. Just wait for a couple of seconds and see. Okay, yeah, I think, yeah, so we're past the time, so we'll skip Dr. Vik's cases and get back to that. So again, welcome everyone. Thanks again for joining in, and all the case contributors, presenters, again, thank you very much for sending in your cases. I think it looks to be as a pretty complex round today. We have around 9 to 10 cases to be discussed, and the chat is open, and you can raise your hands if you have any queries. Without further ado, okay, Dr. Vivek is here. Great. Dr. Vivek, welcome.
Hello, sorry.
No issues.
It takes some time to enter.
All right. We'll start off with your cases.
This is a 2-year-old boy who had come to me for, the history of global delay, small head, decreased tone, central hypotonia. And he had attained neck holding, but then that also as well regressed. And subtle dysmorphism, not subtle, so there was dysmorphism, round face, long head. The thing which was, so you think of something like a global delay, central hypotonia, do a neuroimaging and then decide, but you know that it's going to end up into genetic testing. But before that, the interesting thing which I had always noted in all his results was that deranged liver function test, transaminitis. So that was the only clue to maybe something neurometabolic might be there. So then he had this MRI done.
I have the
Yeah, not subtle. So there is dysmorphism, there is midfacial hypoplasia, there is epicanthus, long bulbous nose, slight retrognathia, and ears also long ears turned back. So and prominent forehead with a hairline which is sorry.
You also have hemangioma, right? If I'm not mistaken.
And a hemangioma. Yeah. So dysmorphic child, subtle dysmorphism, central hypotonia, global delay with a liver transaminitis.
And recurrent respiratory tract infections. Is that a clue?
I think that was more because of his hypotonia that he was having aspirations, more of aspirations, microaspirations.
Okay. Right. With that, I think we have selected images of the sequence MRI sequences. Yeah, slightly pixelated, but yeah, you can see these are diffusion sequences over here. And on the diffusion, though the major findings are in the posterior fossa, I thought there were some hyperintensities, maybe in the globus pallidi. Cannot really make it out on the basal ganglia, but yeah, I think majority of the changes coming down into the brainstem. You have the decussation fibers, which are demonstrating restricted diffusion, the superior cerebral peduncles, the dorsal aspect of the brainstem, and also the vermis has these areas of restricted diffusion all the way down onto the up to the medulla. So yeah, restricted diffusion predominantly in the posterior fossa. I think doubtful in the deep brain nuclear structures. All right, on the T2 weighted sequences, there is some parenchymal volume loss. Again, slightly, yeah, I would appreciate that there are some hyperintensities along the bilateral globus pallidi out there, possibly along the posterior limb of the capsule. And then again, you have the brainstem changes and the cerebellar changes, which you have seen in the on the diffusion weighted sequences. On the side, you can appreciate again there is hyperplasia of the corpus callosum. You have hyperplasia of the brainstem structures. Yeah, so these are the findings. Some with some generalized mild degree of volume loss in the, especially in the supratemporal brain parenchyma. I'm not sure of the vessels if they're tortuous or not. I had only once, single sizes, but yeah, pretty difficult to appreciate the vessels on these sequences. Based on that, I think Dr. Vivek has asked for neuroimaging possibilities. These are the possibilities I thought of, which may help, which may match, especially even the liver failure aspect, possibly pigopathies with the central edematous changes. Not, I think maybe I missed out if the child has seizures or not. If the child did has then IDP encephalopathies, NKH can also have again central edematous changes. Spectroscopy will be helpful. And mitochondrial mitochondrial disorders, especially the tRNA disorders. Sometimes also the DNA, empty DNA mutations can also demonstrate these areas of restricted diffusion. So these, I think, the major differentials we're thinking of, Dr. Vivek, and then I think you're sent for genetics. Would you agree, or would you want to add anything in terms of the imaging or clinical aspects which might narrow down the differentials?
Yeah, on the imaging, I thought of ITP encephalopathy was one, but the posterior limb of internal capsule was not that involved.
Yeah.
And again, maybe a mitochondrial disorder because there was renal liver dysfunction. But there was nothing sort of fitting in. I didn't think of pigopathy, but maybe in future because it looks similar, the MRI, especially the brainstem. So these were the, so I didn't have answer, and the genetic testing was done. And that showed a mutation. And there were two genes, but it was matching with congenital disorder of glycoside 2M, CDG2M, X-linked dominant male. So the child is a male, even though they say that it's quite severe in males and more often seen in a milder form in females. But males are often described to have it. His features were matching. He didn't have seizures. He doesn't have seizures till date. And you know the type of defect, and I hope it's clear, duplication is there, and there is a frame shift mutation leading to the termination. So that's very important. So, and you know, the CR2, which they mentioned, that's just a heterozygous, so autosomal recessive. So it's not, important here.
Got it. Yeah, then once you give me the gene, I looked up if there are any findings in literature with at least the imaging findings. This was a review paper, I think, published a couple of years back, and what they also mentioned was that these brainstem edematous changes also involving the central aspect of the supratemporal brain, especially if you see the globus pallidus out here. But the main findings, what they also have encountered was, though a very limited number of cases, as again brainstem edema and also cerebellar dentate nucleus edematous changes. Some also had panosynostosis. Spectroscopy did not demonstrate any significant findings, which might help in ruling out maybe NKHs and as one of the and mitochondrial disorders as one of the imaging differentials. So this is what we found on it's at least a match with imaging wise. I think also Dr. Vivek will agree that clinically also now it would be a match. Is that right, Dr. Vivek?
Yeah, clinically, but it's just interesting that
Yeah.
you would think of a neurometabolic disorder,
Yeah.
liver dysfunction. So maybe CDG,
Yeah.
you always think CDG1 as cerebellar hypoplasia, and not this sort of diffusion restricted lesions. So that was interesting.
Yeah, I think those are more of the PMM2 variants of CDGs, I think. Cerebral
See,
hypoplasia with atrophies.
yeah, the other one. Yes.
Yeah. Yes.
Yeah.
Can
All right. Yeah, the case is
I
open.
have a question, Dr. Vivek. Did you look or can you look for isoelectric focusing? I'm just asking because in some places this would be a kind of screening, at least beyond the age of 4 weeks. But not all CDG types are, to my knowledge, recognized with this test. You
So
understand my question?
Yeah, surprisingly in India, in spite of all the progress with genetic testing and remaining the transfer and isoelectric focusing has been an orphan investigation, which has not been easily available. I think in Hinduja Hospital, one of our hospitals in India, they are doing it, but otherwise somehow it's not entered the mainstream because it's not easily done. So we sort of are not able to do it, even if we think of it. CDG, even if you think. So we would love to do it, but not that easily available.
Yeah, Hinduja and CMC, both of them are doing it.
Yeah. So these days you think that it will cost you 6,000-7,000, then you'll have to courier. So why not do a genetic testing? So Eugene, the genetic testing ends up being made nearly the same cost after including everything as you compare with transferrin. Am I right? Is that how it is?
Yeah, and in the one sense is if there is a need for reverse phenotyping, if this type has increased isoelectric focus, this one parameters are abnormal, then it can help to
So
cost.
yeah, it might be useful in this patient now that if we want to, then we can send it.
Yeah, you should. It's not. It's about 6,500 rupees. It's not cheap, but it's not that expensive either.
Yeah. So well taken.
You wanted?
Just a detail. This test has to be done on serum and not on plasma. I have collaboration with colleagues in Armenia, and once we made a mistake by sending plasma instead of serum, and then you can't do the test.
Okay. Thanks.
I'll send you the person's number, Vivek, and you can contact her directly.
Sure, sir. Thank you.
Yeah, Sridhar mentions you can arrange it for 1,000 rupees at CMC. So maybe that is also helpful.
That's great.
All right. Yeah, we just wanted to highlight these changes with this condition. Okay. Then we'll move on to the next case then. Oh, right, Dr. Vivek, over to you.
So this is a 7-year-old boy who's still admitted with us. Came to us 5 days back. Severe acute onset headache, recurrent vomiting over 2 days, and parents had visited multiple doctors, suggested admission, but they didn't think the need. But the next day, child was having altered sensorium as well, so he got admitted with us. And there's no history of chicken pox, viral infection, but maybe a possible fall 20 days before. And he had some abrasions on the left side of his hand and face. But in between, he was well. And he just, in emergency itself, he had to be intubated. At that time, his blood pressure was 160 by 120, but after intubation, for the next 1 day, he was actually hypotensive. So we're not even sure if he was hypertensive initially. He had a CT head, which we will show, and then later an MRI. Then CT angios were done. So the CT head, which was done on day 1, had shown hypodensity, and it was really confusing whether he is having press or he's having a stroke. And so we started him after the initial investigations, thinking that this was more like vasculitis on steroids, methylpred, and then his BP increased again. So that really confused the situation. But now sort of we are clear after all his investigations have been done. So just wanted to highlight that in the confusion, which we should never miss, and that was my fault, that we did CT angio of the brain and we did things, and I missed mentioning CT. We don't have MRI, so for MRI we have to send the child outside. So we have CT now, so we did CT brain and CT angio, but neck vessels in the rush I didn't mention. And then later we did neck vessels after a few days, and that does show the problem. So always remember the neck vessels.
Yeah. So I've actually put on the MR. If that's okay to take. I mean, I have the neck angio after that. Before that, I think there are a couple of videos. Yeah.
Oh, this is a different child. So.
Oh, okay. Sorry.
Yeah. It's an NCC patient. Yeah.
Okay. All right. Yeah. So directly coming on to the MR images, you can appreciate these multifocal and confluent areas of restricted diffusion, again, primarily in the posterior fossa structures on the left cerebellum, also along the left occipital and posterior temporal lobes. Bilateral regions, but more on the left hemisphere. Some punctate abnormalities in the thalamus on the left. So predominantly looking like posterior circulation ischemic injuries. T2 sequences, there was this focal height. Yeah, there was this focal hypointensity along the left temporal abnormality in the subcortical cortical regions. Likely for a hemorrhagic focus out there, but other changes correspond with the diffusion sequences. Mild reduction in the supratental volume, nothing very significant at this point of time. Then on the SW sequences, what we appreciated on the T2 hypointensity corresponds with the blooming on the SW sequences, which on the CT did demonstrate hemorrhagic changes. Post contrast, nothing significant in terms of enhancement of the abnormality. I think a Veno was done at that point of time. I think, and I do not appreciate any significant changes in terms of the MRV out there. I've directly gone on to the CT neck vessels. And if you appreciate on the left vertebral artery, let's move ahead. There is, at this point of time, you should be there. Yeah, so at this point of time, you can always appreciate out there is lack of contrast uptake for a short segment out there of the left vertebral artery as it courses through. Again, there is a contrast uptake going into the dural segments and into the posterior fossa. And the SAR sequences, you can, I think, appreciate again the area of non-contrast filling defect in the left vertebral artery. So I think the history of trauma may be significant now, Dr. Vivek.
So that history was not sort of they didn't give that history initially, and we just stopped at CT angio of brain with venogram because we couldn't explain that bleed. I'm not sure how to explain that bleed though. So we thought, is there a CVT? And we just did an angiovenogram of the brain, and we couldn't find it. And I had done a CSF. We had done a CSF which showed IL-6 of 75. And being so much into IL-6, I was sort of more into, some form of vasculitis or a focal cerebral arteriopathy, and started methylpred, which increased his blood pressure. And we thought, oh, is it press or is it? So, the whole picture. So maybe if we had done a neck vessel at the start, everything at the start, we would have been wiser. And we did neck vessels later.
Yeah. So once we see this, at least over here, we do as I mentioned, neck and brain. Then we also do a flexion, dynamic rotation of neck and brain angiography to look for any dissection or any compressive changes by the bony abnormalities in the CVJ or the cervical vertebrae. So that is
do you do it in the acute stage itself? The dynamic study?
Yes.
Okay. Right.
And on the vessel walls, T1 fat set neck vessels, plain T1 fat set can help in demonstrate any thrombus or dissection of the neck. So that is an additional sequence which we use
Right. And would you do a dynamic study here because it's not needed? Right?
Now it's not needed. You have identified the thrombus, but if there's no thrombus or if there's no feeding defect, then to see if there is any mechanical compression, transient mechanical compression, then we do a dynamic angio.
Right. And just interesting that CSF IL-6 was 76. It was really high. So now starting to sort of think whether it's something which, how useful it is sometimes.
Case is open for any comments.
Well, it's not useful. Not useful.
Anyone wants to add anything else? Dr. Prerna, yeah, dynamic imaging, maybe not at this point. We have identified the thrombus, but if usually we don't identify any abnormality, then we do a dynamic.
Reason for the bleed? Reason for the bleed?
So are those two infarcts, one old and one new? Is it something like that? That
No,
area
no.
was atrophic, the left occipital.
No, that is
That's a-
hemorrhage. That's hemorrhage, which is kind of widening the sulcus. You mean this focus, Sridhar?
Yes, son.
Yeah, that's
one.
that's hemorrhage.
Okay.
Why is the hemorrhage?
Um,
Because that was
okay.
very. So how could
It's like a artery to artery embolic stroke.
Okay. Okay.
I had
So
a
that's
question,
a
Nihaal.
Yeah.
Sometimes you suspect this mechanical compression.
The Bohant syndrome kind of thing.
So it's difficult to, convince parents to go for a dynamic angio, especially if the suspicion is not very strong.
Yeah.
Is there any other method of, like, for example, Doppler or anything
No,
else?
we can do a Doppler initially, but usually the compression is at the point of the exit of the vertebral artery from D3 to D4 segment. So I'm not sure if the vertebral artery can pick up if it's more distal.
So becomes a problem because
Yeah.
a very, very strong suspicion to do a
Yeah.
comprehensive study is not easy.
We
Okay.
usually we do it on the MR. We prefer to do all the sequences on the same. If it's not visible on the MR, then only we do a CT contrast. So maybe if it's single study MR, we anyway do it for an angio for the brain assessment of the ischemia. Then at that point of time, only leftward and rightward position of the neck. If that can be done, that would be helpful, I think.
Okay.
Dr. Nihaal, that bleed would be an acute bleed or a chronic bleed? If we
Bleed is
got to
acute.
age that.
It is showing diffusion restriction, so it should be acute early at the same point of time.
Does embolic artery to artery embolic stroke causes a bleed?
Yeah.
Like how does it happen?
Yeah, I suppose it must be.
Cortical veins cortical artery might have ruptured or
Yes.
something like that.
Okay.
Because it's on both the sides, basically. So enoxaparin would have been started, na, Dr. Vivek?
Like now, no, yeah, started now, yes. But bleed was before that, yeah.
Okay. Yeah, so yeah, that we have to continue. The only thing is I have seen posterior circulations, artery to artery embolism with bilateral presentations, but this bleed is something new which I'm seeing for the first time.
Right, because that's something still why the blood is there. So that's something. Reperfusion hemorrhage is common as mentioned. Okay.
Can you say a word about management in terms of treatment and how long you're going to treat?
Right. So we'll give here Clexane for 7 days, I plan, and after that I'll change him to oral anticoagulants and give it for 3 months. 3 months we will do a CT angio again, and if it canalizes, we will stop. Otherwise, for 6 months. And of course, the acute state we have to. So we have ventilated him, raised ICP measures, and these days mannitol somehow has been very useful in the posterior circulation stroke because it had gone out of fashion previously that you just give 3% saline. The last few patients, when we do both, it has prevented decompression and progression. So that we did in the acute state, both of them.
Thanks.
All right. Thanks, Dr. Vivek. Yeah, good teaching point to cover the neck and the brain vessels also when you see posterior circulation. All right, from Jaipur back to Hyderabad.
Yes, sir.
Apurva, if you're there, yeah.
So this child is a 1 year, 3-month-old male child born of a non-consanguineous marriage. This child presented with developmental delay and seizures. So currently at current age, the child is having partial neck control. Rollover is there, sits when made to sit, but no independent sitting. Weight bearing is present. The seizure were multifocal clonic seizures that started from 6 months of age, and they are drug refractory seizures requiring multiple anti-epileptic drugs. On examination, child has normocephaly, but there is horizontal jerky nystagmus. High myopia is there with central hypotonia, risk DTRs. Family history is significant. Mother had infantile onset epilepsy that resolved in within early infancy up to 1 year. And there was some motor developmental delay. She started walking at 2 years, but later she caught up. Currently, mother is a school teacher and having no seizures and no issues with cognition or development. There is a video of the child where you can see horizontal jerky nystagmus is there. So at this stage, with the child having developmental delay, hypotonia phenotype, and nystagmus, hypomyelinating leukodystrophy was one phenotype which was sought of, and this is the child's scan at 6 months of age.
Okay, so selectively put only the T2 sequences. As you can see, diffuse hyperintensities of the cerebral and cerebellar white matter. Even the pons and the brainstem also demonstrates T2 hyperintensities. For a 6-month-old, the plics are not myelinated. The corpus callosum is not myelinated. So it's though it's technically not a hypomyelination radiologically, but as you can see, it's looking like hypomyelinating pattern out there. The corpus callosum also thinned out. So yeah, dealing with the hypomyelinating pattern as Apurva has suggested. And this is the mother scan.
Yes, sir.
Age of the scan. I mean, age of the mother. Oh, sorry, I'm not able to.
6 months.
Anyway, it's
6 months age.
So mother's at 6 months of age.
Yeah.
Is that right?
Yeah.
Okay. So again, yeah, similar imaging. You can see again hypomyelinating pattern involving the suprainfantile brain.
I had a question, Lokesh.
Yeah, Brajesh.
Was this mother and child from Bombay?
Yeah, it's from Bombay and done at Beach
Yeah,
Candy is what I can
from
see.
Nagpur.
Okay.
No,
They
but
have seen you, I think. Yeah.
Similar patient.
They have seen you. They have seen you.
Yeah.
They have seen you and they have
No,
seen.
mother has seen me. Mother has seen me.
Yeah.
The child has not seen me.
Yeah.
The child went to somebody else. I had seen the mother when there were no genetics, and we had diagnosed hypomyelination. But then later on, the child had the same problem, and then of course genetics was done.
Yeah.
So this is the child's genetic report in which TMEM 106B mutation was found at exon 8 heterozygous autosomal dominant. It is a hypomyelinating leukodystrophy 16 being pathogenic. Mother's genetic test has not been done. So here the question was that the phenotype wise mother is on a very milder spectrum when she has outgrown all of it, and cognitively she's a school teacher, so mostly not having any issues, and child is more on the severe spectrum because of significant delay and drug refractory seizures. So is it like a mosaicism in mother, and that is what has caused the less significant features?
But imaging wise, it's a match. The one, I mean, very few published cases, but yeah, I could find these two images in infantile age group, and again, this is at around 19 months. We have diffuse hypomyelination.
What was the mother scan recently? Any? I mean, it's completely okay now.
Yeah, mother is a school teacher currently.
No. What the scan?
Repeat scan is not there.
Gotcha.
But you're right, it has to be a mosaicism because autosomal dominant is either, you won't have the family history, or the parents will not be affected, and if they are, and mildly, it should be mosaicism if the child is more involved.
There are few cases in hypomyelination where they have transient hypomyelination, and with age they improve. I think this is one of them.
Well, that is the MCT, but that is different. Where you get delayed myelination, but once you have hypomyelinating, usually Usually, I mean, I don't know about this particular one, but does it come to that? Usually they don't.
Yeah, there's another TMM one. I'm not sure of the TMM 60 or something, which had transient hypomyelination. So whether it belongs to the same spectrum or not.
It'd be interesting to do the mother MRI for sure.
Yeah.
Because the MRI of the mother looked almost exactly the same as the MRI of the child.
Yeah.
In OMIM, they have mentioned one case report where the father was 60 years old and there was a mosaic mutation and children were more severely affected, but not many case reports are there for this particular mutation.
Actually, the variant is the same around the world. This 754G, this one replacement is the same around the world. The TMEM.
So how will you prognosticate for the child?
Not sure this. I saw them last Sunday, so today we are discussing.
But then it will be useful, as Dr. Dani says, if you repeat mother's MRI, and if it is much better, then maybe the child might have the same course.
Yeah, the mother actually had very minimal delay, and then she walked by 2 years, and then she's been fine. After that, no symptoms. So that's what this is only one case report of father has been mosaic and other children being severely affected. Father is reasonably fine. So that's what we are going to do, the mother's testing, but we wanted to discuss and then take it.
Yeah. So we recently saw TMM 63A, which on follow-up has developed myelination again. I mean, there are published cases, a couple of cases, the same, whether it belongs to the same family or not, that it can be possible. So I think a follow-up will be helpful.
Is if you have myelination, which then delayed myelination, which then myelinates, is not really hypomyelinating.
Yeah.
It's a delayed myelination, which is a different group of disorders completely. So I'm not sure, what are we calling this? This has been classified as a hypomyelinating disorder. And yet, I mean, it'd be useful to do this MRI of the mother for sure.
Sure, we'll do that.
Yeah, Bulent, you wanted to add anything? Sorry, I think you asked me for the images.
Yeah, we'll get the scan of the mother and then get back once.
Dr. Neelu asked, does the gene have variable penetrance? Okay, I think that question.
There are not many case reports for the gene, so I could not find anything.
Yeah, so these were the two ones with images. So yeah, even at 19 months, it's showing some degree of hypomyelination out there. Anas asked, do we expect slightly low cognition in children with hypomyelination, right? Or is it too broad a statement? I think that may be for the neurologist if anyone wants to.
It's difficult to be sure about the cognition status because of the motor disability, I believe. How do you test them for everything?
Yeah, because the family is very high functioning. Relative is a legislator, I think. The father is a legislator and mother is a teacher. I do not know whether it's a relative, this one. It's difficult. But she is normal functioning at least. Yeah.
All right. Once you have a follow-up, maybe we can show those images and see. Yeah, Sridhar mentions you have to borrow statement. All right. Thank you. That we move on to the next case. Sanas, so do you?
Real girl, born to non-consanguineous parents. Concerns were motor delay and some cognitive delay. No swallowing issues, no sleep issues. She attained, so she's this plateauing of motor milestones. She's only able to sit independently, but no standing yet. She's 3 years now. Speech-wise, there's some improvement. She was initially saying babbling. Now she's speaking 2-word sentences, 2-word phrases. So on examination, the short tapering fingers, happy disposition, hypopigmented iris. Growth was as such normal. No facial weakness, no bulbar weakness. Paraspinal weakness was there. No independent standing, but standing with support when made to stand. On follow-up, there was noted to be some inversion of right angle on mid to stand, probably dystonia. DTR was very sluggish. Generalized hypotonia was the impression, motor more than cognitive. Initial clinical possibilities of a neurogenetic disorder like Angelman was suspected, but although there was no sleep issues, major sleep issues, but considering the tapering fingers, happy disposition, hypopigmented iris, these were the this thing. Although the MRI painted a different picture. They had previously, because of the initial hypertonia, they were evaluated elsewhere, where SMA was suspected and SMN MLPA was done. TMS and other biochemical tests were normal.
Okay, we'll come back to the genetics and the labs. Scan done it recently, Anas? 3 years of
Yes.
age?
Yes.
Okay. Yeah, on the T2 sequences, you can appreciate some asymmetrical hyperintensities of the globus pallidi on both sides. Maybe very marginal or mild degree of cortical volume loss, not very significant, I would say. Coming down to the brainstem, again, you have some patchy hyperintensities, periaqueductal, maybe some areas of the dorsal pons. And if you look at the folial spaces, they're slightly widened. So maybe some degree of reduction in volume in the cerebellum. On the diffusion sequences, the corresponding T2 hyperintensity is the left one demonstrated restricted diffusion. This did not have any reversal on the ADC sequences, so the T2 shine through. And on the SAT sequences, you have hyperplasia of the corpus callosum, you have also degree of hyperplasia of the brainstem structures too, and you can appreciate the widening of the folial spaces on the SAG and also in the kernel sequences. So some degree of reduction in the volume in the posterior fossa structures. Yeah. Then I think while speaking to Anas, he had mentioned the happy disposition. Angelman is one of the primary differentials. Anas, is that right? For the child or clinically?
Yes, sir.
Okay, so yeah, Angelman syndrome, I think the imaging has not been non-specific, and these are differentials. I'll open the case for the neurologists and other clinicians to comment upon. But the imaging findings, I thought, if we concentrate on the globus pallidus, I think these are the common differentials which we think about. I'm not sure if it fits into any of these. Associated with cerebellar atrophy, again, mitochondrial maybe, but again, doesn't, maybe clinically doesn't fit. I think Anas can confirm if that is right. Cobalamin pathway disorders, again, can have globus pallidus, some degree of volume loss. So imaging wise, and also neurotransmitter disorders can also have, especially the GABA metabolism disorders can have globus pallidus hyperintensities and volume loss.
Nihaal,
yes,
when I look through many cases at the MR report, this cerebellum can still be in normal limits. Sometimes it's disappointing. You have a patient with migraine or anything else, and it looks like this. It has no progression on follow-up and has no clinical correlate. So this has not really is not really a very prominent finding, I think.
I agree.
Would I just, outside thought, outside kind of thing, sometimes, this patient was delayed from birth, or was it?
Yes, sir. Delayed from birth, but no significant perinatal history was there.
I see.
And no infection
language
also.
Yeah. Language had caught up, but motor is plateaued. So baby attained independent sitting by 9 months, and since then it's been the same. No further. Only standing with support is the new milestone baby has gained, but motor-wise it's plateaued.
I see. Because Angelman syndrome language, of course, would not catch up. Usually, most Angelman syndrome, the cognitive and language delay is more than the motor delay. Both can be equal, but more or less that's very prominent. My question was whether I have a couple of PCAN patients who, of course, they usually don't so early, but they have motor symptoms. Initially, they may be ataxic, and they don't have the iron deposition till much later. And the initial thing is you get only globus pallidus changes because of the central, but then later on, of course, it becomes more obvious. But they don't usually start so early. They usually start after 1.5, 2 years, and that's the time when everything is noticed. And they usually start walking, they have problems. So there's an outside kind of differential.
Something like INAD is also in the something like that. They initially very hypotonic and then later some dystonia.
Yes, but again, INAD would have significant cerebellar atrophy, which is
yes.
Yes.
And the earlier finding is the claval hypertrophy is not there. So
infantile INAD doesn't come with the globus pallidus ions.
Yeah.
They come much later. In fact, iron is not significantly seen in the first few years of life. It's later on you see it.
Yeah, I haven't put up the SWA sequences, but there was no abnormal mineralization or signal changes on the SWAs. I think the INAD is also cerebral atrophy associated with claval hypertrophy is an earlier marker for INAD, which is not there in our case. Dr. Pedna says neurotransmitter disorder higher in DDs. Yeah.
Not sure which one.
Succinate semialdehyde deficiency has globus pallidus changes. The GABA metabolism disorders.
Don't they? They have dentate as well.
Dentate as well, yeah.
Which she doesn't have. And they also are, autistic kind of picture kids. You look at them, they have autistic kind of tendencies. The SSAD8. So I'm not sure that clinically it fits into one of those. He seems to have language caught up, but the motor remains. So it may be a primary dystonic hypokinetic process, because it's involving the basal ganglia, and there is, and sometimes before the dystonia becomes prominent, hypotonia may be more prominent.
Because initial follow-up, there was no dystonia at all, and only in recent last follow-up, we were able to appreciate some asymmetrical dystonia. So maybe it's in that spectrum. So actually, genetics was done, but it showed only LMN, this Nemelin myopathy, which was not a match clinically, nor it was genetically matched. They had done SMN outside, which was normal. TMS and urine GCMS was normal. So organic acidemia, though clinically as well as was not a thought, but at least radiologically ruled it out. One thing was not done is CSF, this neurotransmitter levels. Would it help in this child? Or maybe
I think the scan was done last year. So maybe if you can do one scan with spectroscopy, that is.
Yeah, it's developed by now.
Okay.
So it was in, I think, Jan last year. So yeah, more than 1 year. So we can maybe assess if the volume is static, I mean, if there's progression or not, and then the basic ganglia changes are progressed or reduced.
Okay, thank you. That's a good idea.
This has any, yeah, Sridhar says significant behavioral concerns are there in SSADH. Okay. Bulent agrees, yeah, INAD less likely at this point of time. Okay, so I think we'll go to the follow-up scan at least and then take it from there. All right, Razi, over to you if you're there.
Yeah. So here we have two cases, two siblings. So one is 6 years, next one is 4 years. So elder sibling, they are born to third-degree consanguineous parents with a history of developmental delay in the elder sibling, with neck holding around 6 months and rollover around 9 months. Never attained independent walking, but able to stand with support around 2 years of age. They have like response to name call is they're obeying simple commands. Vision and hearing is normal. And child had seizures, first episode around 15 months of age. Then once in every 6 months, he used to have seizures. These are focal motor and non-motor, every time status epilepticus. And difficult to control seizures on multiple AEDs as well. Perinatal history was uneventful. On examination, weight was 14 kgs and the head circumference was 43 centimeters. severe failure to thrive, and microcephaly was there. And mild dysmorphism, prominent ears and stubby nose was there. On examination, extraocular movements were full range, but had oculomotor apraxia. Fundus was normal, and mild spasticity in bilateral biceps, and cortical fisting was there. And in lower limb, spasticity in left gastrocnemius was there. TTRs were brisk and increased area of excitability. Initially, based on the history, a child had global developmental delay, motor more than cognitive with microcephaly and FTT, and infantile onset epilepsy, multifocal motor and non-motor status, and oculomotor apraxia. We thought of initial differentials where any structural possibility or any metabolic bar genetic or DEE phenotype. Based on the oculomotor apraxia, we like any ciliopathies or tubulopathies also we considered.
So I'll show the images of this index child and the sibling, which have similar phenotype, at least in terms of imaging, and we'll get back to the discussion after that. Yeah, so this is the elder sibling. From top to bottom, if you look at the posterior fossa structures, there is some cystic changes, especially on the right half of the cerebellum, possibly cerebral dysplasia out here in terms of vermis. If you look at the brainstem symmetry also on the axial sequences, it is slightly abnormal out there. Even in going up to the midbrain structures, and there's almost like contiguous cleft going up to the third ventricle. Again, dysmorphic basal ganglia, some signal changes in the basal ganglia on both sides, some P2 hyperdensities. The lower aspect of the basal ganglia are not clearly defined. Razi, at what age was this scan done for the elder sibling? In terms of, yeah, I just need to look for myelination. Yeah, at least the anterior capsules are not clearly visualized. The posterior aspect and the corpus lumen is myelinated. The posterior limb is slightly myelinated, but again, very dysmorphic because of the basal ganglia structures. No cortical malformations per se, at least on these images. Yeah, cerebellar cortical cyst, I mentioned that. T-Reddy sequences, again, you have similar findings. You can appreciate this is maybe slightly more better on the top two sequences on the right. Some degree of cerebellar dysplasia, and again, central changes in terms of the basal ganglia abnormalities, and you have this like a diencephalic, mesencephalic abnormality out there. On the SAT sequence, pardon me, Doctor.
Alic on the
yeah,
left.
I just
Can't see it, no?
Yeah, I just wanted to know what was the age. I'm not sure if it was 6 years or yeah, but you cannot see the alic. Yeah, you're right.
Yeah, so there could be a tubulopathy.
Possibly, yes. Brainstem again, dysmorphic, looks like dysmorphic, the pons hypoplastic. Yeah, this hypoplastic vermis out there. And this is the sibling. Again, if you look at the cerebellum, there's some degree of widening of the cerebellar folia, especially on the vermis. Again, the basal ganglia abnormalities, you have some hypoplasia of the basal ganglia structures, especially the posterior basal ganglia. Again, the anterior capsule is not really visualized. And corpus callosum thinning on the SAT sequences. And again, some degree of dysmorphia, I would say, in terms of the brainstem or hypoplasia, and again, somewhat similar imaging findings to what we have seen, except that the cystic changes are not seen on this child. Colpocephalic type, at least prominence of the posterior aspects of lateral ventricles, I think was there on both the studies. Yeah, the index child had yeah, these two variants.
C3, heterozygous for spinocerebellar ataxia 13, autosomal dominant, which was VUS, not a match. And MACF1 mutation, which was again heterozygous autosomal dominant, but we couldn't find any lesioncephaly as such, but brainstem malformations.
Then I thought maybe if you're dealing with the posterior fossa abnormalities, diencephalic, mesencephalic, genital dysplasias, some of them are known to have basal ganglia abnormalities. I think we have seen 3 cases. One is from CMC and a couple of cases from our center. As you can appreciate, again, it looks like a tubulopathy which has these basal ganglia abnormalities, dysmorphic abnormalities, but in terms of tubulopathy, they usually don't have these hyperintense changes, at least in my experience on the basal ganglia structures. The helics are not visualized in tubulopathies, but these are like gliotic-like changes or hypoplastic-like changes of the posterior basal ganglia. I don't think this is commonly seen in a tubulopathy. And all of them are associated with the diencephalic, mesencephalic junction dysplasia. So I thought maybe that can be a possibility. As Razi mentioned, the match is not there on the imaging phenotype, at least for the first child. And yeah, these are again the differential genes which can cause them. Not sure if tripanopathy can also cause subnormality. I'll open the case for any other suggestions. And the other, yeah, tripanopathy, the typical imaging patterns for tripanopathy, you have dysmorphic basal ganglia, but the hyperintensity changes on the T2 sequences, I think, are not commonly encountered. You can have malformations in terms of the central structures, the corpus callosum cortical malformations. And again, if you look at the brainstem, in tripanopathy on the axis sequences, there is some asymmetry of the brainstem structures, which again can be a pointer for tripanopathy, which is not seen in our case. And the other sibling had these two variants, Johnson and KC and K4. At least imaging wise, again, yeah, Razi, sorry.
Both were not a match for the younger sibling as well, because younger sibling also had like initial development was normal till 6 months, then had developmental regression with epilepsy phenotype with mostly myoclonic jerks, 20 to 25 episodes per day, and difficult to control seizures, drug-resistant epilepsy with microcephaly and severe failure to thrive, and mild dysmorphism.
Right. Case is open. Yeah,
I have not surely understood. The genetic just shown is the second sibling.
Yeah.
And the result is different from the genetics of the first sibling.
Yes.
This is not really helpful.
Yeah.
Second sibling.
I mean, all these genes don't match with the MRI, I think.
Yes.
Yes, sir. Second sibling we have sent only for clinical exome sequencing for tibulonopathy. We couldn't get the answer for that.
Propenas for the microarray help. Not sure. The Brisha mentions Lama A1, Lama 1, yeah, tibulopathy. Yeah. Cerebellosis again.
Lama 1 does not fit overall. I mean, they have normal supratentorial compartment, and the shape of the fourth ventricle is quite characteristic, particularly in the sagittal plane, and this is not the case here. I think it's out of discussion.
Are there periventricular nodules on the left side, Dr. Nihaal? In the axial scan last image?
The CT ones. I think you are saying this one, right?
Yeah, yeah.
So let's.
It's in the team.
It's not there.
Were the tests done in the same genetic lab or in different labs?
Both were done in same genetic lab, sir.
Of course, I have no solution, but perhaps these colleagues can again look at both data and compare and maybe find another solution. I don't know. But I think we are stuck now.
Eugene, we have requested that what you suggested. We have just requested last week. Hopefully, we'll have some answers.
Otherwise, you might have to do a whole genome.
Yeah.
Maybe some intronic variant, God knows.
Yeah, absolutely.
Yeah, still we don't have an answer.
And I think we can go on to the next case. Thank you.
Yeah. All right. Thank you. All right, Dr. Shiji or Dr. Ruchi for that.
Hello.
Yeah, Ruchi, go ahead.
So this is a case of 8-year-old boy who had uneventful perinatal period and normal development, and who was completely organized with no significant family history. presented to us with recurrent episodes of meningitis-like presentation. First episode was at the age of 4 years when he presented to an outside hospital with fever, vomiting, and headache for 3 to 4 days, and there was no altered sensorium. On examination, neck rigidity was present. We did CSF. CSF was done, which showed total 150 cells with neutrophilic predominance. Sugars were 65, proteins were 40.6, and viral panel culture and CBNAT were negative. Patient was treated as pyogenic meningitis at that time and received antibiotics for 14 days, and scans were done.
Okay. Yeah. These are phase sequences. Anything on the phase mentioned, Ruchi? Sorry, the images are slightly that up to me. But in terms of lesions, I don't see any focal abnormalities. I'm not sure the deep brain wave structure edematous or not. And,
They reported it normal only, sir.
okay, so diffusion again, I'm not able to appreciate any focal lesions or this looks artifactual. At least there's some movement on the ADC sequences. All right, let's take it as normal for the initial scan.
Then again, at the age of 5 years, patient had a history of fall while playing from height, followed by loss of consciousness for 30 minutes, following which he developed right-sided facial palsy, which was element, and decreased hearing on the right side. There were no seizures or bleeding from any other orifices, and that time also CT and MRI brain were done.
But no CSF. You did not look for CSF at that time.
No, sir. The patient just had a traumatic brain injury, and there were no fever or signs of any meningitis, so CSF was not done.
Okay.
Okay, so follow-up MRI, I mean, there's some volume loss out there, but there's some periventricular hyperintensity, but I'm not sure of the significance of those findings. All right, we'll move on to the 2 years data. Yeah.
Then again, at the age of 7 years, he presented to us with fever, vomiting, and ataxia with altered sensorium for 4 to 5 days. On examination, neck rigidity was present. CSF was done, which showed 210 cells with lymphocytic predominance. Sugars were 76 and proteins were 52. CSF viral PCR isolated adenovirus, and cultures and CBNAT were negative. Since after giving treatment for 14 days, patient did not improve, so we thought of autoimmune encephalitis, for which CSF panel was sent, which was negative, and G5 IgG was also sent, which was also negative. We also did workup for demyelination and metabolic. Serum lactate and ammonia were normal, and MOG and aquaporin antibodies were also negative. Line probe assay for MTB was also negative, and blood culture showed methicillin sensitive staph aureus. For immunoglobulins, we did immunoglobulins level, and IgE levels were slightly raised. HRCT temporal bone was also done at that time, which was normal, and we treated the patient with IV antibiotics for 14 days, and pulse steroids were also given for 5 days, followed by tapering.
All right, scan done after the CT or at the same time? Sorry.
So this is later.
Okay. Later on, maybe some hyperintense changes in the deep brain infrastructure, especially in thalamus. You see of the flare sequences, the dorsal striatum, and especially actually the basal ganglia appear slightly hyperintense. Pons and middle cerebropencils may be marginally hyperintense, but no focal lesions. As mentioned previously, some volume loss is there, very mild. On the diffusion sequences, no areas of distributed diffusion. Yeah, as mentioned, CT temporal bone was done. No fractures, no physical communications, and the spinal cord also did not demonstrate any abnormalities.
Now again, at the age of 8 years, a patient presented to us with fever, vomiting, and headache for 4 to 5 days with ataxia, and on examination, neck rigidity was present. We repeated the CSF and it showed 12 cells, lymphocytic predominant, and sugar was 61, proteins were 33, and viral PCR, CBNAT, and cultures were negative. We ordered CSF oligoclonal ban, which was negative, and IgG index was also negative. Repeated lactate and ammonia, which were a bit on higher side, but TMS, GCMS were normal. Repeated serum, MOG, and aquaporin 4 were negative.
All right. So as the scan, at least at the scan, you can appreciate focal abnormalities, especially in the posterior fossa structures. The basal cerebral peduncles, the cerebral white matter, right more than left demonstrates these hyperintense changes. Going up to the brainstem structures, you have the pons, which demonstrates hyperintense changes. If you look at the basal ganglia, especially the anterior aspect, anterior mid basal ganglia demonstrates these focal faint hyperintensities on the T2s and the phase sequences. So yeah, some focal abnormalities on the most recent scan. On the diffusion-weighted sequences, the mixed pattern of diffusion, predominantly facilitated diffusion, but some areas demonstrated some low signal changes on the ADC sequences. SWS sequences do not demonstrate any corresponding changes of blooming, hemorrhage, or necrosis. Contrast sequences do not demonstrate any significant enhancement, parenchymal or meningeal enhancement.
We thought of CNS, HLH, and or clippers, for which we did a serum workup for HLH, which was also negative. We treated the patient with 10 days of IV antibiotics, and pulse steroids were given, followed by oral steroids for 8 weeks, after which patient showed improvement. Patient still in follow-up, and we are planning genetics for the patient.
Yeah, in one time and open the case slightly. I don't think it fits into, at least imaging wise, there's no enhancement, at least the typical variants of clippers or CNS HLH. No hemorrhage. Sridhar has mentioned possibility of periodic fever syndrome. NPRL2 and 3 gene mutations can be there.
Is there any eosinophils in the CSF?
No, sir.
So you have to ask for it specifically, because unless you do specific stains, they're very often called lymphocytes.
Sir, we didn't ask. We'll review the findings if possible.
Some sort of allergic meningitis.
We agree, imaging wise, yeah, clippers and HNH maybe just like more likely a genetic abnormality. Yeah, everything has come out negative. I think MOG, the last one at least looked more like a MOG abnormality, but I think you have tested it out for a MOG. GFAP was tested, yes, you're right, Bulent. GFAP also was one of the considerations. GFAP was tested recently, Ruchi, or only the first time?
So CSF, we have sent GFAP, which was negative.
Okay, yeah. Jayan mentions hyper IgE syndrome. Possible, tested for it?
No.
Okay.
I have no experience with clippers at all, but can you exclude it just by the lack of enhancement? Is that sufficient enough? Just a question.
I'm not sure. Again, I've not seen any cases without enhancement. And clippers in pediatrics, I don't think is very well defined.
Another concern here was the cranial nerve palsies, the facial nerve palsy and the hearing loss, which happened after the trauma and which was not explainable. Child has partially recovered and no further cranial nerve palsies. So that was another clinical finding. So we'll go ahead with the genetics.
But is there any chance of, some CSF leak somewhere? CT of the temporal bone is fine.
Yeah.
You need to do more than that. I mean, to find out there's a leak somewhere. I mean, I know you should usually get a bacterial meningitis.
Yeah, bacterial meningitis, sir, exactly.
It's not really looking very bacterial from PSA view.
And he very well responds to steroids, sir. The last 2 events, child was with us. So he very well respond to the steroids. So that's why neuroinflammation was thought of.
Yeah, so some sort of allergic or autoimmune kind of thing. Okay.
And blood eosinophil counts were normal. CSF we haven't specifically asked for.
Is he eating fish a lot?
Not sure.
Parasites, I mean, anyway.
Yeah, we'll confirm that. Okay, sir. Thank you.
Okay.
Thank you, sir.
All right, Dr. Pune, further.
Yes, sir. This is a 5-year-old male child, second born to non-consanguineous marriage couple with uneventful birth and age-appropriate development. He presented to us with a prior history of fever 10 days ago, for which he was admitted in an outside hospital, treated symptomatically and discharged after 4 days. 2 days after discharge, child started developed excessive sleepiness, holocronial headache, and vomiting. And he presented to our ER with 1 episode of irrelevant talk. On presentation, he looked confused and there is excessive sleepiness. His GCS was around 9/15. His BP was in normal centile. Child was oriented, but intermittently he is confused. And rest of there are no focal neurological deficits. Apart from brisk reflexes, rest of the examination was normal. And neck rigidity was present. Initially, we considered acute encephalitis syndrome, infective etiology, and demyelination. And we went ahead with investigations.
You want me to show the MRs or? Sorry, yes.
TLC was elevated with the neutrophilic predominance and platelets were in normal range. CRP was 10.7. Rest of the investigations were normal, absent dengue, serology, and typhoid. And CSF study showed TLC, total cells 70 with lymphocytic predominance. Protein was 32, glucose was 50 with corresponding BSL of 92. Rest of the workup, CSF, CBNAT, CSF viral panel came negative. We looked for demyelination. Serum MOG and MOSD came negative. IgG index was normal and OCBs were negative. CSF IL-6 was elevated, which is 1040. Imaging.
Okay. We have two sets of
Initial
images. Yeah, initial images, I think top of the flare sequences, you can appreciate a focal abnormality in the right temporal lobe. Heterogeneous abnormality with some privileged edema. The walls of or at least the periphery of the lesion demonstrates areas of blooming on the established sequences. Yeah. Similarly, on the T2-weighted sequences, again, you have predominantly hyperintense changes. So with some punctate areas of hypointensity which correspond with the areas of blooming on the established sequences. So a focal lesion in the right temporal lobe. If you look at the diffusion sequences, there is peripheral enhancement, predominantly peripheral areas of, distinct diffusion of the right temporal lesion and no other lesions in the other areas of the brain. Contrast, so very minimal enhancement in terms of contrast, incomplete wall-like enhancement on the post-contrast sequences. All right, we have flare and as demonstrated, minimal enhancement with these changes as mentioned previously. Spectroscopy was done. Spectroscopy demonstrates a significantly elevated lipid peak out there. There are significantly reduced NA creatine choline peaks. There appears to peak around not sure 3.6 to 3.8 or 3.9 parts per ppm. There's slight elevation out there. But other than that, these are the main findings on the spectroscopy. That point of time, I think you're thinking in terms of cerebral abscess, demyelination, space of filling with bleed, and acute
hemorrhagic leukocyte. Yes.
Okay. So if we go back to the first images, if you're thinking of a cerebral abscess, these are some differential features for pyogenic tubercular and fungal abscesses. If you look at the conventional sequences, you have hemorrhagic changes, peripheral wall, peripheral restricted diffusion, and these spectroscopic changes. The possibility of fungal infection would be a prime consideration. And these are also likely Trello's peaks around 3.6 to 3.8 to 3.9 parts per ppm. Tuberculoma is a differential, but in terms of the conventional sequences, hemorrhage is not very not as common as what we see in the fungal infection. Yeah, after that,
We
I think
started
sorry.
the child on IV antibiotics, Miro and Vanco, anti-edema measures were taken, and we, in view of suspecting demyelination to be effective demyelination, we have pulsed the child with MPS. And over the next 5-6 days, child improved neurologically, GC improved, headache, vomiting is subsided, and fever was also subsided. And child was shifted to ward. On day 7 of admission, there is a deterioration in the form of
Just to stop it. I mean,
Yes,
demyelination, hemorrhage is not very common.
okay.
Okay, all right.
Yes, because it is not taking up enough contrast enhancement is not significantly seen. We consider demyelination. And then on day 7, after transient response, then fever spikes reoccurred, headache and vomiting, irritability increased, 2 episodes of focal seizures with left UMN facial palsy and left hemiparesis noted. That is the time we have repeated the imaging.
Okay. Repeat
And
sequences. Sorry. Yeah.
Yes, sir. The imaging and the CSF after imaging.
Repeat sequences. You have additional progression in terms of edematous changes in the right perisylvian region, temporal lobe, occipital lobe, going up to the parietal lobe. You have the region which was demonstrated previously. Again, hemocytin foci on the SWS sequences. On the diffusion ADC, now we have more areas of restricted diffusion going more centrally. Some additional changes of punctate foci in terms of restricted diffusion, also involving the medial temporal lobe and some areas of the cortical subcortical regions of the right occipital lobe. In terms of contrast sequences, now we have more, at least a better defined wall on the post-contrast peripheral enhancing foci out there.
Repeat LP CSF was sugar was 49, protein was elevated 72, and cells were 40, which were decreased from before, and gram staining and ZN staining was negative. We have planned for pyrosequencing, which was negative currently. CSF culture was sterile, and KOH mount was negative. Then we have the antibiotics have been upgraded. Prophylactically, AKT was also started, and meropenem and cyclo have been continued. And we have done a CSF aspiration. Child, and it has showed a frank pus, which was straw colored, no protein, cells were 10,000, which were degenerated. CB-nat of the pus came negative. KOH mount showed fungal hyphae with septae and hyphae, and fungal PCR of the pus was being sent, and Aspergillus came positive. Now culture has also become as Aspergillus fumigatus positive.
Thank you.
And we have started on oriconazole and amphotericin.
All right, cases open. Any comments? I think already someone in chat has mentioned. Rhetoric says Aspergillus aside fungal. Yeah, Kabisha says amazing case. Thanks, Kabisha.
Aspergillus now sort of, we have discussed few cases before, and one has that pattern, especially the wall SWI
hemorrhages.
Right, that hemorrhage on the wall of the cavity often. The first one, yes, this one. This is the 3rd or 4th case we have discussed, and they all turned out to be Aspergillus, right, Nihaal?
Yes.
So that's something very useful. And voriconazole alone is enough. We probably don't need M4P.
Yes, sir.
It's just that we have to give it for a long time, sometimes even for a year. So after first few days or week of IV, you can just change it to oral, which is a good bioavailability. And it's very difficult to decide when to stop, because these lesions sometimes in 2 of our patients have taken up to 18 months to disappear. So one has to keep doing every 6 months, 3 to 6 month MR, screen MR with contrast.
So new lesions, currently we have repeated a CT, just showing a new lesions also after this oriconazole. We have started now oriconazole 2-3 days ago.
And after 8 doses of voriconazole, you have to eight doses you have to do voriconazole level. Unfortunately, it's costly, around 5,000-6,000 rupees. But ideally, you have to keep it in a range.
Okay, sir.
Keep it in a range, which I forgot. So level has to be done.
Yes, sir.
In the blood.
Okay.
Yeah. Thank you. We'll move on to the next case then.
Thank you.
Thanks, Soumya. Yeah. Okay, if you're there.
Yes, sir.
Yeah.
So this is 12-year-old female, first issue of non-consensus marriage, normal birth and developmental. So I'm not able to. So they came with a chief complaint of first 3 days, child had a high grade of fever with generalized weakness, which gradually increased over a period of time. And generally it was on lower limb, followed by it went to an upper limb. And child was admitted for this was an outside hospital. So on day 4 of illness, child had one episode of hypoglycemia. Though that day child had proper food, and until then there was generalized weakness with high grade fever, and she was admitted. On next day onwards, there was gradual decrease in the interaction and weakness, which increased, and then there was a mutism they have observed. They did the labs, but they didn't do the LP, and it was a viral etiology per se, and the CT MRI was normal. So, considering the viral encephalitis, the child was treated with MPS for 5 days, and
sorry, but
so child was treated with MPS, and then generalized generalized weakness still persisted, mutism still persisted. Child was able to move within the bed, was able to eat, and then the child also had a history of urinary incontinence. In spite of MPS, and still she wasn't improving, so she was referred to Bharati Hospital, Pune. As soon as we received the kid, child was lethargic, was unable to ambulate. GCS was 7. Pupils were bilaterally reactive. Child had power of in the upper limb of 1/5, and lower limb there was, so basically the quadriplegic kid we have received. And there was a mutism, altered sensorium. So in view of, she was intubated, and we did the MRI. So
Okay.
based on the
yeah, we'll come back to that.
yes, sir, MRI findings.
Got it. MRI, yeah, we have abnormalities centered in the basal ganglia. In terms of diffusion sequences, some have facilitated diffusion, some areas demonstrate slightly lower signals on the ADCs. So mixed pattern of diffusions, abnormalities in the basal ganglia, also cerebral peduncles. You have these hyperintense state changes. I think better appreciate on the T2-weighted sequences. Yeah, the flare sequences, I think you can better appreciate the abnormalities. Slightly asymmetrical in terms of the anterior basal ganglia involvement, some globus pallidus involvement. In terms of the flare edematous changes, cerebral peduncles also demonstrate hyperintense changes on the flare sequences. Contrast, I think, did not demonstrate any significant enhancement in terms of the parenchyma or the meningeal area. So, no significant enhancement on the post-contrast studies. Yeah, these are the main findings on the main findings are on the basal ganglia and the midbrain. Spine study was done. I think the spine screening did not demonstrate any focal lesions. In terms of post-contrast enhancement, I think there was a comment of quad equine nerve root enhancement. I'm not sure of the, yeah, but if you see it, fine, it's not, I wouldn't say it's very significant, maybe very minimal quad equine nerve root enhancement. Yeah, so then I think, yeah, once the MRI was done, you have.
So on the basis of MRI finding, it was like labeled as mitochondrial. So like we started with metabolic cocktail. Though child had received MPS initially in the previous hospital, and we gave the MPS until then for 3 days, but still there was no response. Then we gave IVIG, and during the meantime we did the LP, as LP wasn't done in the previous hospital. We did the LP findings. The total cell was 3. protein was 64, glucose was 54. Per se, it didn't show any abnormalities. So we have sent it for autoimmune panel as well. NMO, MOC, we have sent even NMDR, it all came out to be negative. So these were the findings, sir. Even we send it for metabolic cocktail, metabolic profile. pH was 7.34, lactate was 2.1, and ammonia was 93. Thyroid profile we did, considering this could be might fit into adolescent girl, just to rule out the some anti-TPO related, so autoimmune antibody. So even that was been ruled out. And the NCB was done because in terms of child was quadriplegic, not responding to MPS, also by followed by IVIG. After IVIG, there was slight improvement was there, improvement in the sensorium. We able to extubate the kid. Spontaneous eye opening was there, but still per se there was no improvement in the quadriplegia. And so we did the MRI after this.
Oh, I have only one MRI.
So, sir, it showed the same finding as per the initial. There was no any as such improvements.
Okay. Would you consider autoimmune in terms of D2R encephalitis or post-infectious process rather than a metabolic?
So actually, this child never really had any abnormal movements. It was just mutism and quadriplegia right from the start. And then just looking, so actually the second one we did spectroscopy, and that showed a lactate peak, doublet.
But your CSF lactate is normal, I guess.
Yes, the CSF lactate was not done. It was only serum lactate.
Serum.
Yeah, it was only serum lactate. My only thing was we do see sometimes the mitochondrial ones also improve after IVIG and steroids, don't we? And so there was only a minimal reduction in the edema in the second scan. Other than that, she still remains mute and quadriplegic. And we were just wondering whether we need to send a wider autoimmune panel and sort of give her rituximab or some other sort of immunomodulation. And that was the main query, whether we're missing out on a diagnosis.
All right. Sridhar mentions Bengtel. Sridhar, you want to elaborate? Hypoglycemia initially may be okay. Deafness is missing, I think, but may not be always there. Fatty acid disorders given hypoglycemia, but is it only a single point hypoglycemia?
Yeah, single hypoglycemia, and her urine ketones were negative. She didn't fit into. She was otherwise a well-thriving girl until this point. Yeah. Sometimes you do have juvenile onset LAs, so I don't know whether she would fit into that.
Okay.
You know, one of the things which sometimes comes with quadriplegia and lesions in the brain like this, of course, they should have some changes in the upper spinal cord, is biotinidase deficiency, late onset.
So we thought about that, BTBRG, I mean this thing, biotin
No, I think that biotinidase, not biotin.
Okay. So,
but I think dermatologically, sorry.
So she's on high doses of thiamine, biotin, and
maybe I have missed your point. Are you considering, or is genetic testing in the pipeline? Because mitochondrial issue was raised.
Yes, sir. It's just that they're having financial issues at this point, so we haven't been able to. We are going with a mitochondrial diagnosis, but we just brought this up in case we are missing any diagnosis and whether she needs any form of immunomodulation, because the IVIG had helped us in getting her off the ventilator in the first place.
Has hearing been checked for the child? This late onset biotinidase do have this sensing hearing loss.
So we checked it with the second scan, and when we thought maybe not biotin, so we thought about Megdel and other things. And then we checked the hearing, and Bera was fine.
Okay.
So it's very symmetrical, isn't it? In
Yes,
favor of a metabolic genetic condition.
Agreed.
Even a CSF lactate would be useful.
So the MRS had a lactate peak, sir.
That was very much in favor of a non. I don't think it's really an immune process. It must be, unless you've done the lactate peak was done from some other.
From the necrotic area in the.
So that doesn't help. You have to do from another area which is not involved. Necrotic area will show high lactates.
So I think it was done from the left putamen, probably, which shows a bit of necrotic changes.
Okay. Suggestion for CSF IL-6 from Jayant and Dr. Vivek. Abhisha says lay is a possibility. Yeah, thanks, Abhisha.
And Acadi-Gutierrez IFI-H1 variant. So there's an AGS variant which presents like this acutely.
Sir, would they have a background of any developmental
Normal.
delay? Okay.
Normal.
Okay, sir. Okay, sir.
Okay, so I think we'll await the genetics. Sorry, if you're sending for genetics and IL-6 levels also. All right, this is the last case.
Yeah,
okay,
yes, sir. Yes, sir. Yeah. So this case, so it's a 1 year, 8 month boy, first issue of non-consensus marriage with normal birth, developmental and family history. So he came to our OPD with an history of he had an abnormal eye movements while following the object, and with there is an head jerks noticed by father by 6 months. So this is an eye movements following head jerks, and it has been progressive last 6 months.
So apraxia, titubation, or what is the movement disorder? Sorry for
looks like an apraxia, sir. But it's not constant. Like whenever there is an object in the midline, he doesn't have that defect. Like but it's while moving the object, he have this kind of an head jerk along with an head movement and eye movement.
Can I jump in? You have to
Yes,
be careful that you look for saccades and not for pursuit movements, because pursuit movements are intact. So the apraxia is probably not intermittent. It's a matter of the testing.
Okay. During the examination, child no significant abnormality we find. The pupils were fine, tone power reflexes were good, and we did do the metabolic workup as well for this kid. And even we had an ophthalm evaluation which was normal. VP was done, it was normal, though we didn't had any antenatal or birth history, significant birth history. And then we went for an MRI.
All right, MRI, quickly going through the MRI sequences. Supertenderly cannot appreciate any significant findings. No malformations, no signal changes, no abnormalities, no significant volume loss. Coming down to the posterior structures, you can see median clefting along the vermis, which is abnormal. If you look at the T1 weighted thin cut sequences of the superior cerebral peduncles, it is elongated, though not severely thickened, but it can appreciate the elongated appearance of the cerebral peduncles. On the SAT sequences, you have slightly horizontal orientation of the superior cerebral peduncles out there. There is a prominence and tortuosity of the optic nerves, prominence of the perioptic sheaths on both sides. In terms of imaging possibilities, thinking of Joubert syndrome, I'll let Eigen elaborate on if that's a possibility and other what are the other conditions which can present with that. So these are typical variants of Joubert syndrome. You have thickened superior cerebral peduncles. You have variable involvement of the cerebellum in terms of median clefting is another important feature. Cerebral dysplasia is an important feature. The milder variants, which may or may not, I think, fit in our case, Eigen has published extensively. Again, you have mild molar tooth appearance, which can be seen in some of these disorders. Without further delay, I'll open the case if people agree and if there are any other comments.
I fully agree. This is very suggestive of Joubert syndrome or Joubert spectrum. If you go to the next slide, you have to be aware that the dominant heterozygous SUFU mutations can be missed if you just look for a Joubert panel, because the Joubert panel looks at recessive forms. So this 41 Joubert syndromes which has an OMIM listing. They are autosomal recessive, and one OFD1 is X-linked recessive. But this particular SUFU variant with mild molar tooth is heterozygous dominant, familial, or de novo. And if I may add, just from the clinical perspective, if you have an infant with an ocular motor apraxia, the important differential diagnosis is number 1, Joubert, number 1b, SUFU variant, number 2, Lama-1 or Poretti-Bolshauser, and number 3, rare metabolic conditions. And not criticizing your assessment from a metabolic screening initially and from VIP, you don't learn anything. This is usually normal.
Okay, thanks again.
Yes, so I think the VP and other things were done before the child came to us. Sorry about that. But yeah, once we saw the scan, actually, we felt it was reported as normal, and we really wanted the second opinion because the parents were quite keen on a diagnosis.
I had a question, Dr. Bolshauser. In the past, we used to have these patients with normal development when there was no genetics, and they are isolated oculomotor apraxia. It was called Cogan syndrome. I don't know if you are. This is a part of Joubert, so you think it's different?
It's a matter of definition, but some of these so-called idiopathic Cogan syndromes, if you repeat again a detailed, a high-level MRI, you see the mild molar tooth, and in most of these, we have found the SUFU mutation. I'm not saying that there is not the option of having an idiopathic Cogan, but this is least on the list. Before I would exclude other things. Yes. And just even in a very good genetic lab, the diagnostic yield is not 100%. It's maximum 80%. So as I said, 40 or 41 types are listed in OMIN. There are a few additional genes known, but they have not yet an OMIM number.
Thank you.
Thank you.
Yeah,
sorry.
You have one more minute, excuse me.
Yes, yes.
The dominant SUFU variant is special in two things compared to some of the Joubert patients. They never have a regression. They never lose skills. They get better. And in contrast to a large proportion of Joubert patients, they do not develop multi-system involvement in terms of retina or liver or kidney.
Thank you, Dr. Bolshauser. That was very helpful.
So, Dr. Prerna, we await the genetics follow-up.
Yes, they are coming back for the follow-up. We'll be sending the genetics. But then it was so regarding the SUFU, I wasn't really aware, and it was a learning point. Thank you, Dr. Bolshauser.
Pleasure.
Right. And yeah, that's our last case, everyone.
Thank you.
We'll meet again in a fortnight's time. Thank you again. Thank you, everyone, for your expert comments, cases.
Thank you. Thank you.
Thank you.
Bye-bye. Thank you very much.